Hello and welcome to a special interview for The Wire. With India's COVID-19 cases leaping towards 500,000, is the country losing the fight against the virus? That's the key issue I shall discuss today with the former principal of Christian Medical College in Vellore and the chairman of the Scientific Advisory Committee of the National Institute of Epidemiology, Muliyil. Professor Muliyil, as of today, June the 23rd, India has over 440,000 cases and they are growing at around 15,000 each day. This means India now is third largest in terms of daily increases, fourth largest in terms of total cases, and eighth in terms of total fatalities. Are we losing the fight against the virus?
There are no winners and losers. We could have done without the virus, I agree. But once the virus comes in, it has a schedule. In the schedule, it will accomplish certain things and is right on track. What we can do, we should do efficiently. And for the time being, our focus should not be in the wrong direction. Let me explain what I am trying to do. When the virus came into our country, first we said we'll block it. Then we said no, we'll eliminate it. But apparently the virus has come to stay. Now, those two dreams have been shattered. I agree, but they were just dreams. And it has never been easy to do anywhere else in the world except probably a few small countries. So now the major part of the India is got this virus acting. And the question is that don't have to accept defeat or saying we didn't do it well. We tried, it is catching up, it is spreading. So what do we do now? Prevent deaths.
Can I stop you at that point? Before we come to the question, what do we do now and how do we prevent death, try and get some sense of how much it's spreading. Last week, I spoke to Professor Ashish Jha, the director of the Harvard Global Health Institute, and he says India probably already is adding a total of 50,000 new cases each day. He says by August, we'll be adding possibly 200,000 new cases each day. I also spoke to Ramanan Laxminarayan, the director of the Washington-based Center of Disease Dynamics, and he says that by September, India could have 200 million cases. Do you agree with those forecasts?
Well, the question we had to ask before I answer that is what do we want to happen in future? Would you like to stop the epidemic as soon as possible? So if you have that in mind, this should not worry you. Epidemic is always infect people, and if the population is non-immune, they will spread. There's nothing we can do in the absence of a vaccine or a drug. Be realistic. These numbers are there and we know it is spreading all over. And I must tell you frankly, I say the sooner the better. The whole thing is finished off. And we have a point at which we will stop. And I told you before too, this is when we reach our herd immunity.
If I understand correctly, you're saying don't be alarmed by the figures quoted either by Ashish Jha or Ramanan Laxminarayan. The size and scale of India's population means that the number of people infected will be enormous. And secondly, as you're saying, once a virus enters the country, it will spread. And because we have a big population, it will spread in large numbers. Have I correctly understood you?
Absolutely. Perfect. And remember, You said first, second, third, everything. India is the second largest country in number. So it's only natural our numbers will be stunningly bigger than many other countries in the world.
Except that 200 million in just 3 months is frightening. That is almost one-sixth of our population. It's almost 17%. Have other countries been infected in Europe and America to this high percentage?
Well, these are anyway estimates, but remember our target is 50% of our population to be infected. Okay, so on the way to that objective, and you have no option, that's where you get a stable level of immunity. So it will spread till it infects almost half the population. So that is the number we should expect.
So we should expect that at the end of the day, 50% of the Indian population, which is roughly speaking something like 670 million people, will be infected.
Correct.
You really mean that? We should expect that half the population will be infected.
Absolutely correct. And that is the estimate I'm working on, and it argues in this manner, manner in which we say it, in urban areas, the R naught will be higher. In the rural area, the R naught will be lower. So the required herd immunity will vary according to region and according to population density. So a 50% is a good working figure.
Let me put this to you. Tens of millions of migrant workers have gone back to their villages in rural UP, Bihar, Bengal, Orissa, Chhattisgarh, Jharkhand, and presumably they've carried the virus with them. Would you now, in 2 weeks or 2.5 or 3 weeks, expect a surge of infections in these rural hinterlands?
The thing is, what our expectations are is primarily what comes on the TV. Remember, this disease is a mild disease for majority of the population. A small minority gets into trouble. But when you take a city like Mumbai, Delhi or Chennai, the numbers are large, the visuals are not good, but in a rural population, the spread would hardly be noticed. And that is the reason is because majority are subclinical. And here is a 71-year-old man has a chest pain or a breathlessness and died. Who is going to link it up with COVID? So the drama that COVID creates is primarily because it manifests itself powerfully in large population. London, Mumbai, Chennai.
But you're saying something that's both interesting and also a little disturbing. You're saying that in rural populations, it won't manifest itself so much because a lot of the infections will be subclinical. That's reassuring. Those people won't be ill. But you're also saying that those who fall ill won't be diagnosed, and therefore there will be COVID deaths in rural India we won't know about because they won't have been diagnosed as COVID deaths.
There was no reporting of COVID deaths. There will be reporting of deaths as usual, but to diagnose a COVID death in Indian condition, it will be difficult from rural India. And it will look sporadic, but it happens in all over the vast rural areas of India.
But then can I assist you? If there is no reporting of COVID deaths from rural India, but simply the reporting of deaths, i.e. deaths will not be categorized as COVID deaths, then it's quite possible you could have a lot of COVID deaths and not know about it. You're saying the opposite at the moment, that there will not be a lot, but you could have a lot as well. Your argument works both ways.
No, I am saying the expected deaths will occur, but you won't see it. Deaths will occur all over Indian villages, but you will not hear them as COVID. The problem comes up is this when there is a rush of cases, like in a city, and there are deaths you're counting. It looks frightening. But in real sense, every year we have certain number dying. It's about 10 million people. And some of them, and majority of 50% are in the age group 60 plus. And most of the COVID deaths will be in that age group. And they are not different from
But can I
anyway
ask you,
those.
will there be a lot of excess COVID deaths in that age group in rural India?
Well, when I look at it, that the elderly who die, practically everyone have some comorbidities. So also the young one. So there seems to be an acceleration of death. People who are frail, people who have heart disease, kidney disease, they probably are dying a little earlier because of the COVID. I'm not saying that is acceptable. All I'm saying is explaining the dichotomy between rural and urban scenario.
I understand that. It becomes more dramatic in urban scenarios. It's almost unseen in rural India. But let me then put this to you. When do you expect the peak? A report recently published by The Hindu, done by some ICMR experts, but unfortunately it's been disowned by the ICMR itself, suggested the peak could happen sometime in mid-November. Professor Ashish Jha of Harvard said to me, it may happen later, possibly in December. What's your idea? When will we hit the peak?
I don't believe there will be a peak. There will be a peak for a locality. I can think of Chennai peaking soon after, say, Mumbai, or around the same time as Delhi. These peaks are there because they are accelerating. Now, what we can do is by lockdown and things like that, try to slow it down. That is if you are very fond of having your epidemic around for a longer time. So that is subject to not be interfering. Yes, I am very hopeful that, for example, Chennai, by August, it will start showing signs of recovery.
By August, Chennai will start showing signs of going down.
You will know it's a peak only when it starts falling. So I am suggesting that by middle of August, you will find it's coming down.
So what you're saying is that there won't be a nationwide peak that applies to the whole of India. There will be local, regional peaks, and you believe that Chennai will reach its peak sometime in August, and then the numbers will start diminishing. Do you have any sense when Delhi and Mumbai will reach their peak? Delhi at the moment looks particularly frightening.
I think Delhi is facing it quite calmly. I think their administration has been facing it. I'm not very good at this kind of game, but so far from the direction they have been going, I think they will peak earlier than Chennai. But let me also tell you something. In the front of mortality also, things have improved management-wise. So these cities, with all the facilities they have, should also be able to reduce mortality despite peaking.
Now, one more question. Roughly 4 weeks ago, on the 23rd of May, the health minister told the Economic Times that the virus was not that virulent in India. And he buttressed his argument by saying that only 6.4% of cases go to hospital, around 3% go to ICU, under 0.5% need ventilator support. And he said this compares to 3% in the rest of the world. Do you believe there are good scientific reasons for believing that the virus is less virulent in India?
No, there is only one virus, and there is only one species, Homo sapiens sapiens. There's nothing called Homo sapiens sapiens indicus. So it's the same virus. So the patterns will be similar, if at all anything. The only difference will be in the reporting of deaths and nothing else.
Now, in the two earlier interviews I've done with you, you said that India's great strength was the age profile of its population. 90% of the Indian people are under the age of 60. And you said this meant that if they were infected, it would be either asymptomatically or very mildly. And as a result, you said the best strategy for India was to protect the elderly, to protect those with comorbidities, but let everyone else get on with their life. Of course, wearing face masks and trying to maintain social distance. And you added, we need to put a ban on large gatherings, weddings, funerals, cinema halls, theaters. But now that we're talking about a possibility of 230 million infections in 3 months' time, is this still the right strategy or have you changed
Yes.
heart?
The reason why I said half and so many is that because of the belief in herd immunity. And once the herd immunity kicks in, and I'm hoping in India there will be pockets which already demonstrate herd immunity, where when you see a high level of serology positivity is associated with a fall in cases, then people will believe it. Seeing is believing. So I am consistent on the same argument. There is no other method. Elderly will have higher casualty. Keep them out of the fight. Young should boldly walk in because their mortality is low.
Let me pick up on something you said. You believe there are pockets of India which are already demonstrating herd immunity. And this reminds me that there is a second part to the ICMR serological survey which has been leaked but has not been officially released. And this second part of the survey applies to what are called containment zones or hotspots. And the leaks suggest, and I emphasize these are leaks, that perhaps 30% of the population in these containment areas have been infected. Are these the sort of pockets that you have in mind where you say herd immunity may already be demonstrating itself?
Absolutely. You have got it correctly. I know that particular study, and I know they have done very, very meticulously. And they have been very strict in the way they did all the testing, and you can believe when they say these numbers. And when it comes out, it will be easier to talk about it. And I'm saying those particular centers will show, especially the large population groups from the survey has come up, it will show whether we can anticipate this herd immunity to function as expected.
But it's interesting you say you know that study, you say it's been done very meticulously. Why hasn't it been released? It would be a great source of comfort to the Indian people. It would suggest that in critical containment zones we're very close to herd immunity. Why isn't the government releasing it? It seems to have delayed and decided to sit on the report rather than make it public.
See, COVID fight is like a football game. The first half you have to score on the eastern goal, and the second half, unfortunately, you have to score on the western goal. So in the containment phase, you want to reduce the number of cases. When it comes to community transmission, and really what you hope is we reach the herd immunity faster. So I and you would be quite happy to see fairly high levels of immunity already reached. For some, it may be disturbing. Okay, is it an inventing failure? It is not. We have done quite well. That's what we should say.
So you're suggesting that the government has withheld this report because people will misunderstand. and believe that high levels of infection is failure rather than a good sign.
Well, that is one explanation. Or it could be that they wanted to scrutinize this thoroughly before it is published.
Okay, maybe that's what they're doing, although they are taking a long time to even scrutinize thoroughly. Let me put to you two problems that people bring up when your theory of building up herd immunity by allowing young Indians to get on with their lives is discussed. The first problem emerges from figures which the Ministry of Health made public on the 20th of May, just a month ago. Those figures make clear that 48.8% of all COVID deaths in India have been people under the age of 60. In Europe, according to the WHO, the percentage of people under 60 who died of COVID is just 5. So, in percentage terms, it's 12 times worse in India. Doesn't that raise serious questions about your theory?
They call me an epidemiologist, but before that I was a field worker. I worked in all the villages. People's reactions you should know. With all good intention we make regulation, but it is very often counterproductive. Think of a guy who is a middle class person, who is a 71-year-old father in one of the slum areas or in a small housing area. This guy at night, he has got a fever and slight breathlessness. Well, what would we do given the circumstances? We would say, listen, if I went to a hospital, they will test me for COVID, and if they find I also have this, they will now quarantine me, and my wife and children will be alone. So, given this problem, who will come to a hospital or a facility that can check up? They may go to a private practitioner or even a traditional practitioner. I am trying to tell you this. When you have a system that is not welcoming you to come to a hospital, but it adds on to your woes, you will unlikely to approach the system when some trouble happens.
So you're saying that the reason or the explanation why 48.8% of COVID deaths in India are people under 60 is because these people, when they fell ill, didn't go to hospital for a variety of reasons. The stigma, the quarantine, the hospital doesn't welcome you. Had the healthcare system been better, the percentage of people under 60 who died would have been a lot smaller. Is that what you're saying?
I'm saying we are missing a lot more above the age of 60 in who are sick and dying because many don't approach these special hospitals.
I've got it. It's not that hospitalization and stigma has raised the number of people who've died under 60. It's diminished the number of people who've died over 60. In other words, people over 60 don't go to hospital, they die quietly at home. If the true picture of the people over 60 who have died were known, then the percentage of people under 60 would be a lot less and not 48.8%.
Absolutely. And this particular figure is a sure indication there's a severe selection bias in the care that we are offering to the general public.
This leads to the second problem with your theory. Your theory critically depends on our capacity to protect the elderly, but most of us live in 2 or 3 generation homes. The young go out and come back and they're with their grandparents and parents. And inevitably, they will infect their elders, and the elders won't therefore be protected. They'll be infected. That's the problem with your theory, that in India, because of the way we live, we cannot protect the elderly.
I agree with you, but there is nothing called a perfect solution. We can't protect all the elderly. Can we protect half the elderly? Maybe 75% of the elderly? So the question we have to ask is, it doesn't work in Dharavi, it can't work anywhere else. I'm going to tell you, in many places, or any parts of India, it can work. Make it work there. Once, this is the kind of messages people should get, that Elderly can't join this fight. It's a safe disease for the young, but unsafe for the elderly. Instead of quarantining people and things like that, the clear, sharp message inside the house, they can protect the elderly. They should wear masks if it's a small house.
Can I put this to you? It seems from your answer what you're suggesting is that the herd immunity building up process would happen. This is an emotive way of putting it, but at the cost of the elderly. We cannot protect, as you said, all the elderly. At best, we can protect half. They need to wear masks even at home. But your strategy of building herd immunity is going to happen at the cost of the lives of many elderly. That's inevitable.
No, I didn't mean that way. The herd immunity will evolve whether you like it or not. All I am saying is, when you look at the spread of disease and say, oh my God, are all the people going to get infected? Here I am saying, no, halfway through we will get a respite. It has to stop. It may not be exactly halfway through, it may be 60%, I don't know, but it will stop. So when you calculate your plan in terms of what is the requirement to meet this emergency, how many people will die, we have to calculate using herd immunity in the equation.
Okay.
That's what I'm saying. But if in the process you also manage to keep the elderly out of the fight, the manifest mortality that comes on at the end of it will definitely be better, lower.
That I understand. But it all hinges on that condition. If in the process you can keep the elderly out of the fight, the way we live as families with many generations under one roof, the way we live in small homes where you don't have separate rooms, means that the risk to the elderly is going to be there. It cannot be minimized. But then that's a fact of life that we have to accept. You're nodding your head. Is that yes?
Absolutely. This is not a miracle cure. All I am saying is, given the situation, I am going to give the onus of protecting themselves to the elderly. Tell them, please, protect yourself. Don't worry about anything else. And that, if a large enough number can manage to do carefully, we may make an impact.
The onus of protecting themselves is to be placed on the elderly themselves. That's a bit daunting for many people, a little hard to take, but that is also the reality. Let's take a break at that point. When I come back in the limited time available, I want to discuss with you whether the Indian healthcare system can handle what could be 200 million infections by September. And secondly, how important now at this stage is testing and what sort of testing at that point. See you in a moment's time after the break. Welcome back to a special interview for The Wire. My guest is the former principal of Christian Medical College at Vellore and the chairman of the Scientific Advisory Committee of the National Institute of Epidemiology, Muliyil. Professor Muliyil, at this point, where the forecast that you agree with suggests we could have 200 million infections by September, what sort of testing do we need? And how important is testing at this point?
Remember that we need testing to know whether it's a COVID or not. I am specifically mentioning this now because we see of late that the mortality of severe COVID has come down because there have been a series of changes in the management schedule, and many centers are reporting a dramatic fall. For at least to manage these cases properly, we need to know whether it's a COVID pneumonia or some other viral. So I think that testing facility, whether it's a current testing of RT-PCR or even a rapid on-the-spot test, which is quicker in the rural area, may help because there are some very manageable intervention, manageable even at a taluk hospital, seems to be appearing on the horizon.
So
So
if I understand you correctly, you're saying hereafter we're testing not to check the spread of the virus, but to check whether people are infected so we can manage them better to prevent mortality.
absolutely right.
Does
That
that
is the most important.
Does that mean that now that so many tens of millions of workers have gone back to rural India, we should be carrying out those antigen tests in rural India very quickly? Because those can give results apparently in 15, 20 minutes, and they can be pretty accurate on the positive side. So, should we be enhancing antigen testing in rural India to find out how many people are infected to be able to protect them and ensure they don't die?
I'm a little skeptical about this trying to contain the virus all over India. We have seen from the recent survey that the disease is spread all over. You know, when a disease comes into a country, which is limited to a few loci, trying to get rid of those areas, you know, that is feasible, possible. And Kerala did it temporarily. And I hope they continue to succeed. But it's not going to be easy when the rest of the country is all teeming with the virus, trying to get rid of virus from village A, village B. Is it on the long run a feasible idea? I don't think so. How long will you do it? For the next 30 years? That's not possible. So, the point is that we have finished that phase of it, containment. We have to now understand the virus is all over. Now we have to ask the question, how do we limit the spread so that it doesn't become an avalanche? And the main thing is to use personal protection methods. That is the correct way to do it. Now, you may want to check the spread of the virus through a systematic planned surveys. That's a different matter. But catching people and isolating, that period is almost over.
Okay.
Because it is not going to be cost effective or feasible in
So
all the.
just to translate for people who may not understand the technical terms you've used, you're saying there is still a need for nationwide regular serological surveys to keep a sense of the spread of the virus, but no longer should RT-PCR tests being done to try and contain the virus. Now we should limit those tests, either RT-PCR or the new antigen test, simply to ensure that we medically treat those who are infected properly and ensure they don't die. That's the change in focus of testing that you're advising.
To my mind, that is the only way we can proceed, because today it makes a difference to know whether this particular pneumonia this person is suffering from is COVID or not from a management point of view.
Which means that actually you should be testing those who have influenza-like symptoms to make certain whether it's a influenza that's COVID-related or if it's a non-COVID. That should be the focus of testing. That should be the focus of testing.
Right.
Let me come to a second issue. You know the Indian healthcare. If we end up with 200 million infections in September, which is the forecast you accepted, can our system cope with that number?
Well, there is one section that is not likely to be able to meet up, and that is those who require ventilators. And ventilators are difficult to manage. It is we don't have enough expertise to spread across the nation. And so, but A large number of lives can be saved with proper management, nursing care, and oxygen. So, to that extent, we can make an impact without elaborating or without enlarging our facility. But the thing missing will be ventilator support for the very severely ill. Yes, that will be a limitation.
So, where our healthcare system, when we have 200 million infections, will fail is in the case of people who need ventilator support. But the majority need oxygen and good nursing, and you think there we can rise to the occasion. You really believe that, even if we have 200 million infections?
Provided you don't still think it is a stigmatizing disease, you still recognize the fact young people don't succumb to it, and you have to have a positive attitude toward the whole disease and not worried about the number game, who has more numbers, less number, and then see that's why I am uncomfortable with RT-PCR. We keep counting them and putting up on the board and saying so many hundreds, so many. Doesn't matter. That disease will spread. Worry about clinical cases, in influenza-like illness, and there is where your management lies.
One last question. The government has made it clear that they intend to do three things to beef up the healthcare system. First, they're going to make available telemedicine platforms for the functioning of ICUs in small towns and District 2 and Tier 3 towns. Secondly, they're going to train doctors to become intensivists by putting them through 30, 40 hours of instruction. And in Delhi, at least, they're talking of getting final year medical students to either work as helpers in ICUs or to even work as junior doctors in hospitals. Are those the right sort of steps in your eyes?
I am not an expert on ICU care, but from what little I know, I wouldn't be happy to be admitted to one of those ICUs.
That's very clearly put. You do not have faith in telemedicine run ICUs.
That's correct. It's frightening. As it is, ICUs are frightening.
Right. On that very sobering note, Professor Muliyil, thank you very much for talking to me. Take care and stay safe.
Thank you.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.